So I'm the co-founder and president of a nonprofit organization, NGO, called the Democracy Collaborative. We've been around about 20 years. One area of our work, it's just one, is we work with very large place-based anchor institutions, hospitals, universities, city governments, cultural centers, and so forth, because we think these assets that are in our communities are essential to rebuild the basis of our local economies, to make them vibrant, equitable, inclusive, resilient. So what I'd like to do is just say in my brief remarks here, I'm talking to those of you who are from the Bay Area who are not part of the conference that's taking place right now, this Healthcare Anchor Network. And I want all of you in the Bay Area to know what's represented among the people that are here from all over the country who are in this Healthcare Anchor Network. We have about 35 of the most significant health systems in the United States sitting in this room. They represent an incredible amount of firepower, and I mean that in a really good and benign sense, for our communities. And what do I mean by that? In this room, among the people that you see sitting at the tables with you, are represented more than 1 out of every 10 hospitals in America, more than 1 million employees in these institutions, more than 50 billion, with a B, $50 billion of procurement annually, and more than $150 billion of investments in endowments and investment portfolios. This is an extraordinary economic opportunity for our communities, and the people that are here in this conference are committed to leveraging their supply chains, their hiring, and their investments for the benefit of our communities. And they call this the anchor mission, conducting themselves as health systems and hospitals in ways that's not only good for them, but is good for the community. Because if they're doing their work in a way that's good for the community, they're going to create healthier communities. That means healthier residents and populations, and that's consistent with their missions as healthcare systems. So I want you to know who you're with, because this is a really important group of people, and it's representative, they're representative of a vast movement that's taking place in this country, not only in healthcare, but in universities, in city governments, in many other sectors of our society. And at this time when I think for so many, and I think it's probably safe to say here, maybe a little less safe to say in Cleveland, Ohio, where I live, but when so much of our national discourse is so dark, when it looks like so little can be done, when we look at what's taking place in Washington, D.C., and we see almost nothing positive taking place in our communities, rooted in place in nonprofit organizations and others like those of you here in the Bay Area, and in these large place-based institutions, there is a real opportunity for our country. And so I'm just so thrilled that we at the Democracy Collaborative can be part of that, and that you're here to be present to this great new movement that's taking place in America. With that, I'd like to introduce David Ansell, who is going to moderate. I hope I got that right? David Ansell is going to moderate this panel. David is has become a very dear friend, and we've known each other all of about a year. But he contacted me about a year ago and said, we're up to some very interesting things in Chicago. He's Senior Vice President with the Rush University Medical Center in Chicago, which is adjacent to West Chicago, which is a neighborhood of 400,000 people, many of whom are living in very difficult situation in low-income neighborhoods. And David said, I'd like you to come to Chicago and see what we're starting to develop here, because I think you'll find it interesting given what you're up to. And I had the opportunity to go there last year, and I knew I was in the right place when David said, the meeting we're having tomorrow with 200 people from the community. It's taking place in Malcolm X Community College. So I knew I was in the right place, because if you're going to Malcolm X Community College, how good is that? So I want to introduce David and have you take it away, and have everyone, I hope you enjoy yourself tonight. I think you're going to learn a lot from this extraordinary panel, and there's always going to be more food and drink here. So thank you very much.
I'm pleased to be here today. We're relatively, I'm David Ansell. I'm a physician, and my role at Rush is Senior Vice President for Community Health Equity, a relatively new role in our organization. And I'm really pleased today to sit on this panel with, I might call them the Fab Four of Anchor Mission, Anchor Healthcare Mission. I just want to briefly introduce them, and we're going to jump into questions probably for a little less than an hour, and then have 15 minutes of questions from the audience. And I think someone's going to keep us on time here. To my left, Randy Oostra, CEO of Promedica. Bechara Choucair, my friend and colleague, formerly from Chicago, now strangely in San Francisco, from Kaiser Permanente, Senior Vice President and Chief Community Health Officer, the fabulous Michellene Davis, EVP, Corporate Affairs of RWJBarnabas Health. And on the far left, unfortunately today, Tessie Guillermo, Board Chair of Dignity, could not be here today. So unfortunately, we had to get a ringer from the crowd, and Pablo.
You'll notice
Bravo.
that it comes from titles, that this is a VP,
Yeah.
EVP, SVP.
Yeah, and he's wearing his funeral suit today to impress you. Anyway, I do want to start off with a question, because we've all taken this on, and I just want to ask an overarching question. Why was this so important to your own institutions that you take on an anchor mission, and why is it important that we lever these assets to improve community health? How did this occur, and what's your take on the anchor mission in your own institution?
Well, good afternoon, and beautiful setting. It probably started about 10 years ago for us. We went through a community needs assessment and did what health systems typically do. We did something nice. We thought we would do some learning, some large teaching maps around nutrition. And we hired trainers, and we put them in schools and different clubs. And what our trainers came back with was the fact that the kids they were working with were hungry. And kind of long story short, we were shocked. That's not what we signed up for. We said that's not our problem, and really became quite, interested, convicted by this whole notion that hunger is a health issue in this country. And that led us down a whole path. We had Jeffrey Canada speak at our a meeting early on, and he said, nobody's coming to save you. You have to save yourself. And really, as we looked at our communities, we're from Ohio and Southeast Michigan, communities that are hard hit. We are the largest employer. We have significant resources. And we were sitting on our resources, yet around us, we're in a non-growth market with lots of issues. And at some point in life, you either say, we either do something to help or you don't. And so through a series of activities, we became very convicted, not only in the social determinants of health, but also this notion of anchor institutions, that if we don't do something to help these communities that are struggling, nobody is going to. And as we already talked today, we have the financial resources, we have the people resources. And for us, it was just a matter of trying to figure out how we could fit in and try to help others address the problem, many people that had been there before us. So for us, the more that we got involved, the more convicted we became. And now it's really, as we look at our system, there are three things we're interested in. It's clinical care, the social determinants of health, and anchor institution strategies. But for us, it is the absolute critical thing for us to do, and it's the way to make our community successful.
Thank you. Bechara.
Sure. Thank you, everybody, for coming here tonight, and welcome to beautiful Richmond in California. And I'm ready to answer this question, but I figured Michellene here wrote some beautiful notes, and I was going to use them to they look great. So, yeah. But I guess I'll take that on my own. But, so I think for us, David, as an organization, we have deep roots actually here in Richmond and in California and across the country. And we've always been this organization that's been about two things. We are about improving the health and well-being of our members and improving the health and well-being of communities. We've had the same exact mission for 70 plus years, and I think we're at a point where we absolutely are convinced that those go hand in hand. Because if you think about it for a minute, there is no way you're going to be able to improve the health and well-being of communities if we're not doing a really good job at improving the health and well-being of our 12.3 million members across the country. But at the same time, there is no way we're going to be able to optimize the health and well-being of our 12.3 million members if we're not really thoughtful and really active and really dedicated on improving the conditions for health and equity in the communities where those 12.3 million members live. And when we do that, when we focus on conditions for health and equity, not only our 12.3 million members would benefit, really all 65 million people who live in our communities would benefit. And that's why for us as an organization, as a care and coverage entity, the community health work is really core to who we are as an organization. It's core to our strategy. So our community health work is not this, nice thing that we do on the side. It's really core to our business strategy. And we invest every year over $2.8 billion in community health efforts across the country. And we in the community health team, and I see so many of my colleagues here, we're looking at the $70 billion that this organization invests in our communities as a way to improve community health. So we're kind of greedy. We're good with the $2.8 billion that we invest every year, but we're always asking, what happens with the other $70 billion? Who are we hiring? How are we investing our treasury dollars? How are we procuring services? How are we building facilities? And that becomes core to who we are as an organization to improve community health. So that, in a nutshell, why we are in this business as an organization.
I think two things. One, we are in this business because how can you not be, right? So my CEO of RWD Barnabas likes to say all the time that we have now changed our mission, right? That being said, if in fact this is a change, I'm not certain what it was before. Because I will tell you this, right? So the reason why we are in this space is because we are the largest integrated healthcare system, but only in one state, in the state of New Jersey, which many of you know, right? It's the 14th wealthiest state in the country. That being said, we have some of the more communities that have vulnerable populations and high concentration within our footprint. It really helps to better understand how it is that if we continue to do what we always have done, we will always get what we have always gotten. And that was no longer going to be enough, not when we literally own a hospital in the state's largest city, right, for 119 years, and they still have Black infant mortality that is worse than 3 third world countries. So if that's okay with you, right, but that was enough to keep me up at night, right? So as we take a look at the broad really what our breadth and our depth was as a system, then we know this. We know that you don't get to treat nearly 2/3 of a New Jersey population. So of our almost 9 million, we treat 5, right? And not begin to really decide that we want to treat the whole person, not just the disease that they presented with, but actually, right, their entire being. So that's one reason why we're in it, right? Because you can't be in these communities and not care for these people, not just their chronic disease. And then two, because of the fact that while I talk about our state of New Jersey, I am actually from that which is one of the poorest cities in that state. So I'm going to show up here because this is sacred safe space. Somebody say sacred safe space. And so we're going to be authentic in this space, right? So while now I'm the executive vice president of this large-scale organization, I'm from a city that was literally the most dangerous city in America for literally 15 straight years. And so what I will tell you is that we finally began to realize and understand as an institution that which Miss Mamie always knew. And that is, I cannot be well when in fact I am concerned about how to feed my children or where they are going to sleep tonight. And so that is really, right, the impetus behind why it is that we've decided to lean all the way in to this space. Because we really wanted to, honestly, be more about the doing and less about just the talking about it. And then we wanted to ensure that we were treating individuals as they were, in a respectful manner, but really in a situation oftentimes of compromise as a result of systems and structures that contribute to them being there.
Anyways, so for our organization, how we got into this anchor really began with this history of the sisters. I mean, if you look at our religious sponsors who created our organization, they started as educators and then moved into the community to address basic needs, such as access to food, access to clothing, and then much later, they began to be taking care of sick folks. Later on, they built these huge facilities that now turn into these huge systems. So our roots are basically rooted in the communities that we serve. Moving forward, one of the things that we have observed is in times of crisis, for example, when we have just recently had the financial crisis. I call it recent because I don't believe I think we're still in it for many of us. We saw a lot of businesses move out of town. Businesses that came into the community, and the community invited them in, said, we're going to give you tax breaks for you to bring jobs into the community. When times were tough, they were the first ones to leave. Same thing with bankers and with the mortgage crisis. So for us, that meant that as an anchor institution, we do not get up and leave. We're there, and we're going to make everything possible by using our assets to have the community succeed. And whether it's through investing, whether it's through hiring locally, or just buying from the local produce.
We're the probably newbies on the block. I would say we stumbled into this. And we stumbled into it, I want to say there was a number of stimulus events that occurred. The shooting, police killing in Ferguson, the shooting in the church in Charleston, actually in Chicago, Laquan McDonald being shot. There was a huge amount of distress within our organization. We're on the west side of Chicago, been around for 180 years, 150 years in this neighborhood. And as we began to look at what we were doing, we were undergoing a mission change from being the best healthcare outcomes to improving health. We understood that the social mission of our institution was being tested. We looked at our diversity inclusion strategy, which had been there for a long time, and at the rate at which we were going, perhaps in 100 years or so, we would have the degree of inclusion around the table that we wanted to have. And so I think, and then we looked at our programs, and so we had a lot of community programs for many, many years, but they were never designed to move a dial or move a needle on anything. And yet we could name a few things that we did were really out of the box thinking about change, a few little things that we did that said, boy, that really made a difference. What made a difference? One is we thought big about it. We didn't think small, we thought very big about it. Two is it was always with partners. That anything that we could look at in the success was with partners. And then we looked at, did a community health needs assessment like everyone else did, and we took a hard look at mortality in our neighborhoods and life expectancies. And we took that up to our board, and we decided that we were going to take on a health equity as one of our cornerstone strategies. And really everything has followed from that. We took on we Googled anchor mission, and we found the Democracy Collaborative. And we've had the help in Chicago as a consulting alliance that comes out of the commercial club of the city of Chicago that usually does civic projects, came and worked with us, and we could accelerate our work here. So it's, on one hand, it's internal work around aligning our business units towards this, but in a larger way, it's all about what partnerships can we make. And in the end, we said to ourselves, we are responsible and we are accountable for these health outcomes in the city of Chicago. And then if we don't act, it'll be just business as usual and it won't change. And so that was our thought process. We're literally a year and a half into this. I do want to ask this question, because at Rush, we actually started by making this a strategy. That's how we started at Rush. But I want to ask where this sits in your organization in terms of the board and the senior leadership, and how it sits strategically within your organization. And what do you think, ask the question, does it need to be strategically located, or can this be a tactic within a couple of departments?
Well, I think it has to sit at the highest level of the organization. I think it has to sit with your senior leaders. And the reason for that is clear. Even when we started our work, we told the people doing the work not to tell anyone, because it's kind of a push for board members who come from a for-profit. I think some of them still think it's a phase we're going through, and that they just want us to get it over with. Our physicians understand it, and I think anything you think about from physicians, they see it, they just have never been equipped. Our employees, it's a struggle, because again, they give me more money, give me more nurses, give me more this. And so it's this constant effort to make sure that we continue to push forward. And, I have board members say, we've done enough, let other people do the work. And I think that's kind of the struggle. So I think it has to sit at a very high level. In our case, we have a president of social determinants who gets up every day and focuses her time on social determinant work and anchor institution work. And I think it's critically important. We do, board meetings where we do kind of deep dives. So we do kind of case study approach. And our last board meeting, it was all about social determinants of health. So we spent 2 hours talking about social determinants, asked questions about what their comfort level was in continuing to invest in these kind of strategies. So in Ohio, we're 49th for infant mortality for African American babies. And it all has to relate to social determinants of health. And so this idea that we can stop working on it, giving up on it, is really not something that we want to do. But I think it has to be in the constant dialogue and constant attention of people. So we talk a lot about it. We talk about what anchor institutions are. I do think a lot of the folks in this room know about it, but I've been in 2 meetings recently with large groups of people. And if you ask, do you know the name anchor institutions? And you ask, how many, raise your hand. It might be a handful of people. And so I think it's a lot of work to do. I think there's a lot of work ahead of us. It is the absolute right work to do. We're spending $3 trillion in healthcare in this country, 19% of the GDP. It's going to continue to go up. And so the only way that we're going to fundamentally change what we do is to really think differently about healthcare. Alex Azar, the new head of HHS, said last week he's really wanting to accelerate work out of hospitals. So you begin to think about that. You think small town America, frontier communities, the work that we do, and you wonder, what are we going to do down the road? When small hospitals close in communities, it's going to have a devastating effect. It's going to have a devastating effect on people. It's going to have a devastating effect on the local economy. You can't take those jobs out of those communities and have those communities continue to prosper. So what are we going to do? What if we can remake the American healthcare system, make it much more socially based, make it much more anchor based? What if we took some of the payments that we use today for clinical services, luckily, hopefully most of you aren't doctors, and take it away and put it much more into public health and social services? If we could do that in this country over a 10 or 15 year period, I think we'd have a lot more success. And probably if we could redesign the healthcare system, that's how we'd redesign it in the first place anyway.
It starts at the board, and everything that we do gets incorporated into policies. So the board is very supportive of what we do, and they're very aware of the need of the communities that we serve. From there, they're the ones who approve policies that are being brought forward by our senior leaders. So senior leadership is very aware of what the policies are, and they're also very aware of what the needs are of our communities. So it starts for the board and works all the way down. One of the things that we've seen in the transformation of this is where at one point many years ago, the board was focused on community benefit reporting, the community health needs assessment, and that was it. Now they understand the social determinants of health. They're very aware of the need of our community to address the social determinants of health. So as long as they're aware, then it just flows down from there. It comes from the local level folks at the facilities as well, as they express the needs of their community to their senior leadership, and then their senior leadership reflects into the overall system. So there's all, in Dignity Health, everybody is really involved. Everybody tries to be aware, and everybody tries to educate one another, but it's embedded into our policies.
So, if I may, that's why we all want to grow up and be dignity. What I will tell you is that it is undoubtedly an element of our strategic plan. It is actually the sixth pillar. And it had to be the sixth pillar because while I am incredibly, I'm going to go ahead and utilize the term blessed to have a CEO who understands it and speaks this language and, most importantly, is educable around it, right? So he knows that he knows a great deal about this, but he also gets this all-important part that he doesn't know everything about it, but wants to, right? He's a voracious reader, and so the poor man, I'm always giving him something in this space. But so to that end, I had a fantastic CEO who completely understood. I have a champion that I never saw coming in the chairman of our corporate board. And so where's the camera so Chairman Jack Morris is a godsend because he is so completely committed to this. But the reason why it had to be threaded into our strategic plan was because those two individuals are not the ones who have to do the work. Right? So I needed our institutional asset leaders to understand how to do the work. So as an executive vice president at the system level, I answer only to the CEO and to the board chair. So I was kind of like, okay, well, so we have those, so that's a check. But how do we make certain that human resources and treasury and facilities and construction management, right? How do we ensure that our chief financial officer, who is to whom supply chain answers to, fully understands this? And so I have to say this as well. That, yes, you heard me mention the issue around Black infant mortality. You heard my fellow panelists and a man who I admire a great deal, Randy, mention maternal mortality. So what is really keenly important here is the fact that the social determinants of health have a great deal to do with these outcomes. But that is not solely the only issue that pertains to why we have these outcomes. And so it's really important that as you do this work, that yes, you do it through a lens of ensuring health equity, that you are also quite cognizant about the way in which we need to not reduce but eliminate healthcare disparities. Because if we start out talking about let's just reduce them, then you'll be satisfied with what you essentially have right now, right? And so there are two articles right now. One, there was a piece by CBS News, and then there was another in the New York Times about the issue of weathering and the impact. Come on, sister, I see you nodding your head, right? About the issue of weathering and its impact on African American females. But what I will tell you is it is about the fact that it is not just those issues in and on their own, separate and aside. The reason why race is an indicator is because it highlights the issue and the impact, and you'll hear more about this from my twin brother, David Ansell, of structural racism and the impact that it has had on proliferation of these outcomes in the communities that we serve, period. So the reason why it has to be in your strategic plan is because of the fact that individuals, for whatever reason, have sometimes a slight difficulty in trying to have that full conversation, right? No one wants to feel like they are in and of themselves a bad person, and they are not. What they are simply an individual who continues to do things in the way in which large-scale organizations have taught them to do them, right? Which is of exclusion and not inclusion. And so we've got to begin to do this work in a real way that operationalizes it. Because we talked this morning about socializing it, which is so important, but operationalizing it is what actually gets it implemented and executed to get it done.
I think for us at Kaiser Permanente, it really starts with the board. And I think, over 10, 12 years ago, the board of directors decided to create a committee that's focused on community health. At the time, it was the Community Benefit Committee of the board. Still has the same chair. Now it's the Community Health Committee of the board. Dr. Cynthia Tejas chaired that committee for years now, and really is championing at the board level and driving our community health strategy as an organization. At the same time, make no mistake, my boss, our chairman and CEO, drives that. And he is very vocal about it. He talks about it everywhere he goes. So I think it's a combination of definitely leadership at the board, absolutely leadership at the CEO level, but at the same time, it's also what's happening with our national leaders as an organization. Laurel Young, for example, she's our head of shared services. She's responsible for all procurement. She, with her team, were responsible for driving our minority, women-owned businesses, veteran-owned businesses procurement to over $2 billion in 2017. It couldn't have happened without Laurel's commitment to that. Same thing around the building. Jody Lesh and John Yamamoto in Southern California saw an opportunity in building a medical office building in the Baldwin Hills Crenshaw area. They spent a lot of time thinking about what would it look like to have a community-based health center in that facility? Spent a lot of time with community town hall meetings, roundtable discussions. I think I saw Beth earlier today, who's here, did a lot of that work with the community. And what did we hear from the community? We want jobs, jobs, jobs. And what did we do? We made sure that we've worked with organizations that helped us create the pipeline to have local folks from within 2 to 3 miles of that medical office building helping with building that facility. On the environmental stewardship work, I see, Kathy Gerwig here, who's from the program office, spent a lot of time and energy building enough momentum to make sure that we have commitment to become carbon net neutral by 2020, right? And a lot of other elements around food, sustainable food, lots of efforts around some of the work that we've done around waste reduction, clean energy, that wouldn't have happened if you didn't have leadership from the program office driving this work. But make no mistake, a lot of the work also is happening from the ground. Our work in Baltimore and the zip code 21223, we have absolutely nothing to do with it from the program office. It's all driven by our team. I see Alma, I see the folks there who, kind of got to that community. It was one zip code, it was specific jobs, it was specific efforts around. I know we've partnered with many organizations in that area to make a difference. So I think it's a combination of things that bubble up from our regions, from folks who are doing the real community health work on the ground at a zip code level, and it also goes all the way up to the board that's making sure that is setting that strategy, driving that strategy. But I'm very clear in my mind, in Bernard's mind, our CEO, I'm accountable to making sure that this thing evolves. So I'm the biggest champion. I'm talking to folks all the time about it. I'm driving, creating the energy and the momentum to make a difference. So that's how I see it from my lens at Kaiser Permanente.
So maybe this is a time just to get a show of hands from the audience. Raise your hand if this is board senior leader directed in your organization. Let's see around the room. And then raise your hand if it's occurring at the level of a unit within your organization, but not up to the senior leadership team. So kind of a mixed bag out there. I can tell you at Rush, our community work was always grassroots. It's just the nature of an academic medical center when you've got lots of students and nurses and other people did this work. What really made a difference was when the grass tops took this on for us as an organization, meaning the board committees and such. The other thing that happened for us at Rush, we realized that if we did this alone on the west side of Chicago, if we just became an anchor institution with all the help from Democracy Collaborative and our other partners around here, it wouldn't be a drop in the water. And so in Chicago, we've created a place-based initiative looking at the west side of Chicago, a neighborhood of about 500,000 people. Is bigger than many cities, high hardship neighborhoods. We actually built upon the health plan that Dr. Choucair did when he was Commissioner of Health in Chicago as a way to think about this work. And now we've gathered other institutions in the city, healthcare institutions, in what we call the West Side Anchor Committee to do this work together. One thing that was critical for our work was not just to embed it at the board in a senior leadership level, but actually understand that there are various components to it. There's the healthcare equity piece, like how is our delivery system perpetuating historical inequities? There's a community partnership piece. How do we overcome 150 years of well-earned mistrust in our neighborhoods in Chicago as really a bastion, an institution that's been a bastion in many ways of white male privilege? Internally, our diversity and inclusion group caught onto this work and just came up with a 5-year plan that includes in that plan demographic parity among our leadership and our board. Chicago's a third white, a third black, and a third Latino, and I can tell you, despite much progress within our institution, we do not reflect the institution. So I think bringing this into this institution has generated sort of the hearts and minds of people at the grassroots as much as it has been directed by the senior leaders. And sometimes we have to run to catch up, like your folks in Baltimore, with people who are on the ground doing the good work and doing it without asking permission. And I think that's one of the great things. But I do want to actually do a follow-up question, because one of the important things for us in our institution was to name the root causes and name them specifically. And in our community health needs assessment, in our videos that we've done about it, we have actually, and in our quality plans that run up to our board, we've actually named structural racism and economic exploitation as being root causes of this problem. And we felt that we needed to do this because that was the giant elephant in the room for us, for why were there such great health inequities affecting black and brown communities around us. And we think that that's given us a certain degree of, there's a humility around this. As a white man physician who's progressive, it took me many years to say the words racism. I didn't like the words segregation and disinvestment. They seem to be passive versus direct. But I wanted to ask my other partners around the table, how important has it been in your institution to have an honest discussion at the board level, the senior leadership level, about root causes of these inequities in our communities? And I'll let anyone go first.
Did you see all my brothers just turn to me? I don't know. Pablo, they might have been looking at you, Pablo. That's such a shame.
I'm on the other side of the wall.
So guys, so we get the fact that these are really tough discussions to have, right? Like, we understand that. Some of you look like you're a little bit uncomfortable, and we need to make certain that you don't feel that way, because what we need from those of you who are in this room, who are not necessarily representatives of the black and brown communities that we're talking about, is the fact that we need you to be our greatest ally. We get that the well-intentioned still nevertheless have to fight through everything else that we've learned. So being able to understand and fully grasp the fact that we all have our implicit bias. We do, right? We do, because we're human, right? And by that very nature, we are just going to have that thing, right? So if you have a very close relationship with your family and you might believe in a higher being, I'm going to be naturally drawn to you, right? Because I've got a bias sort of around that issue. And the same is that for others, with just a different way, right? In a different twist. So how are we beginning to talk about it?
So I think the other, I think a lot of times you look at boardrooms of health systems, it's not a discussion they've ever had before. So I think a little bit it's related to kind of the same discussion with social determinants. It's education, it's data, it's awareness. For a lot of our board members, they've never had this discussion before. They don't know the data. When they found out that, infant mortality statistics, they were shocked. Some of our doctors were shocked. So I think a lot of the issues that we're talking about are, the type of issues that we just get in front of boards, and we have this ongoing dialogue. And I think that's probably the biggest risk we face in continuing these dialogues, not only in this room, but for, the 4,000 other hospitals that exist in America, which probably aren't having that discussion. And the whole idea then again is to listen to voices that aren't at your table, getting people at your table that you don't typically talk to, and really beginning to work in a very collaborative fashion. I think we would all say that health systems have a bum rap in most communities. They usually, when we show up, people think that we're know-it-alls and we have all the resources, and we're not welcomed at a lot of tables. So, a little more humility and listening to people and what they have to say in communities and neighborhoods has been a hard lesson for us to learn, and I think that's probably one of the most, important things. Our metrics are different than ever before. One of our metrics has to do with job creation. My personal goals have to do with non-healthcare job creation and women and minority-owned businesses. That's a very different goal to give a president of a health system that we would have had 4 or 5 years ago. And I think I think we just need to continue to have these dialogues in communities. I think we need to think about it. Data is tough for people. In some cases where I think it's evident, I think it's not as clear. The issue about toxic stress in America and the effect of toxic stress, and then life expectancy and toxic stress, not only from an infant mortality, those are great sort of pieces of information that we need to get out to people. Because I think we find in most boards, the way they got nominated, the way they came on a board, this is a whole different discussion than they've ever had. And they bring a different lens. And so when they think of their fiduciary duty and what they're required to do, what they think they're required to do is really kind of those traditional fiduciary duty sort of things. I have to make sure the balance sheet is careful. I have to make sure there's an operating income. So to begin to have them think about these kind of issues in their community, their role in the community as an anchor institution and social determinants is a really heavy lift for people that have not normally thought about that. So I think it's all about education. I think it's all about data. And I think the other piece that we haven't talked about yet tonight is research. We're devoid of research. There are spots of research with social determinants. There's spots with some of the health inequities, but it's not readily available nor readily dispensed in the healthcare industry. And we put up these kind of bright lines. We put on bright lines in social issues. We put on bright lines with aging. We don't deal with those issues typically. And the good news is we're starting to deal with those issues, and I think it's a matter of coming. What you worry about, though, is it just sits in groups like this, and that it doesn't get disseminated. So we would hope that either CMS or others would start to mandate more of these sort of requirements, and that's the way you're going to get American healthcare to change. A lot of great, things we can do, but I think it's going to take some kind of top-down, bottom-up effort to really change America.
Thank you.
I think for Dignity Health, we're lucky for the reason being that we were started by women religious. So first of all, women were our leaders. Our board is very diverse. Our executive leadership team is very diverse, and the organization as a whole is very diverse. I think there's a couple of things that it's very heavy on our executive director, or Lloyd Dean, CEO, is cultural trauma and violence in our communities. And I think that's tip on his mind most of the time. And I think overall, if it isn't one day a week or every day that he mentions, we got to do something, Pablo, we got to do something to address cultural trauma, to address the violence in our communities.
Those in the room here were born and raised outside the country. So I'm one of those. I was actually born and raised in Lebanon. And then when I immigrated to the United States in 1997, as a little kid growing up in Lebanon, you'd think the United States is amazing, is fantastic. There's no racism, there are no issues, there's no homelessness, everybody has enough money to do things they'd want to do. Everybody get to live the life they'd want to live. So when I first immigrated, my first few years I did my residency training in Houston, Texas, I was in shock for the first couple of years. I trained in the healthcare for the homeless program. It was an awakening to see people sleeping under bridges, to see people lined up for soup kitchens. And throughout the years, I got to realize, how racism and inequity have had a humongous impact on people in this country. And this is a hard conversation to have. This is a very hard discussion to have. In most instances, I don't have the right vocabulary, I don't have the right terms, I don't have the right sentences. I see the team from the Mid-Atlantic here, and we had an amazing conversation a couple of weeks ago when I visited with them around this issue, around racism, around inequity. How do we start talking about it in a way that adds value, in a way that really brings us to think differently as an organization? And I think for me, at the end of the day, one, I have a lot to learn personally, and I look at that with humility, with a lot of being a little bit anxious to kind of learn and be able to talk about that. I know I make mistakes, and when I do, I always blame the fact that English is not my first language, so it always works, even though Josie, who's sitting there, is just shaking her head. Please don't say that. But the reality is, though, it really all boils down, in my perspective, on we have to be intentional. We have to be intentional in our partnerships. We have to be intentional in our dollar allocations. We have to be intentional in our decisions. And we do have an amazing group of leaders across all of Kaiser Permanente that's always thinking with that lens. When we put grant proposals, how do we evaluate those grant applications with an equity lens? When we're creating partnership and identifying partners, how do we make sure that we're identifying the right partners? And we're gonna make mistakes. And when we make mistakes, guess what? We take a step back, learn from those mistakes, correct those mistakes, and keep moving on.
I think this has to be the room where we have the more difficult conversations. But now I want to move this to the audience and ask for audience questions of our panel here as we close off the last 15 minutes between you and Bed.
Hi, thank you all for sharing this evening and for your commitment every day for this difficult work. My name is Roberto Vargas. I work with the Center for Community Engagement at UCSF. And my question is, it seems there's some agreement, at least in the room, that social determinants have a tremendous impact on health outcomes, and our investments in social determinants are likely to have better outcomes on health than simply investing in healthcare. And I heard recently that Kaiser made some investments in addressing housing and homelessness. Here in the San Francisco Bay Area, as I'm sure everyone's heard, we're struggling with a housing crisis or an affordability crisis relative to housing. And I'm wondering, what can we do to get the organizations we work in and represent to invest more in housing and less in homelessness? What do you think are the barriers, and what do you think will help us get there?
Thank you. What a great questions. And I feel every day I'm so privileged to be part of an organization that's always asking itself, what does it mean to be a health organization? And for us, health and housing are interconnected. And I know for everybody in this room, there's really not much distinction between health and housing when it comes to the life that people would want to live. And so being part of an organization that engaged our CFO, engaged our Treasury Department, and said, is there an opportunity for us to take some of those investment dollars that we invest in the market and invest them in opportunities that would allow us to not just have financial return on investment, but really social return on investment? And we're really excited that we'll be able to focus on housing. Affordable housing is a significant issue that every one of our communities is dealing with. And, even if you think about the Kaiser Permanente's communities, it's basically the hub of the housing crisis in this country. It's San Francisco, it's Oakland, it's LA, it's San Diego, it's Portland, it's Seattle. So we had to do something in that space. And part of our anchor institution strategies was leveraging our investment assets. And we had to learn a lot from many of you in this room who've done this work before us. You know, Pablo at Dignity Health have done a lot of work. I saw Tanya and the team from Trinity Health, who kind of was the first space where I got exposed to this work. So for us to be able to step up and say, here's our contribution to spark that conversation, here's a commitment of $200 million that we're going to be investing in opportunities for affordable housing in our communities, is really the right thing to do. But that alone is not enough. You know, we know that this is an important step, but this will build on the additional investments that our leaders in all of our regions have been investing in, supporting wraparound services and supporting transitional housing and supporting resources available to shelters. It's really in investing in opportunities to prevent homelessness from the get-go. I mean, all of those are really part of an overarching strategy that needs to happen for us to be able to make a difference. And since I do have the microphone, we had an amazing event on Friday in DC where we've announced our investments. We've joined mayors and CEOs for housing investment. And we had a great time there, but there's one person who couldn't join us who's been probably the biggest champion of this work at Kaiser Permanente since my day one. Rachel Myers, can you please stand up and be acknowledged? Thank you.
So can I add something around housing in San Francisco? So in San Francisco, Dignity Health has really focused a lot on housing. There's a rental assistance program that we partner with the City and County of San Francisco. There's a San Francisco Accelerator Fund, which actually is also a partner with the San Francisco Mayor Office of Housing to be able to rapidly move into properties that are on the market. Before it would have to go through the city procurement, that would mean delays, and therefore those properties would be gone. One of the things that we're experiencing in San Francisco and in many cities is how quickly developers move in, purchase properties, and take advantage of whatever piece of land is available. In San Francisco, we don't have land. So most of our investments have been in partnerships with organizations who can rapidly take advantage of purchasing and stabilizing neighborhoods. So we're not just dealing with homelessness, but also stabilization of neighborhoods in San Francisco.
Another question here.
Good evening. My name is Anthony Galassi with a statewide organization called the Green Lining Institute, and thank you to all the panelists for your words. My question is for all of you. When it comes to the social determinants, each of your organizations is a champion and is an example of the innovative work that needs to be done. And at the same time, when we talk about confronting structural racism and improving the social determinants of health, so much of the values you all champion need to also be adopted by institutions that are outside of the scope of healthcare. So my question is, what needs to be done in order to take the framework you all are so keen on and have that be asserted in other spaces and other sectors across the board and across the different communities you work in?
Maybe I can just start, because in Chicago, having this discussion internally took some time and effort and figure out how do you frame this discussion, how do you have it with the board, and we've had it with the board and such. But what helped us is we named our employees, our low-wage employees, as our first community. And if you look at what's happening to low-wage employees across the country, people are suffering, and it's in the data. This is where data is very, very helpful. So we looked at who's making under $18 an hour in our system, and who's among those are having to take hardship, meaning they're going into their pensions to pay for rent or evictions. 20% of our employees under $18 an hour in Chicago are having to take money out of their pensions. I guarantee you it's the same in all of our workplaces. People are struggling. The data in America is 40%, 45 or so % of Americans have trouble meeting rent and eviction. This stuff comes home, and guess what? They're the black and brown people in Chicago, in rural America. It probably looks a little bit different, but they're the people who aren't thriving. And I think actually that's a great way to get other industries to do it. I've been talking to some of our corporate partners and our banks and things like that to do the same sort of analysis that our Treasury did at Rush, because these are the people you're walking by every day and seeing, and it takes an abstract issue and personalize it. So that's one thing that we've done to bring home how does structural racism get perpetuated in an institution without racists, just by historical injustices being perpetuated.
Yeah, to add to that, I think your concern's right on, because what you worry about, so if you went to a healthcare meeting 3-4 years ago and you asked about the social determinants of health, nobody raised their hand. I was at a meeting yesterday, everybody raised their hand. Everybody's doing social determinants. So what are you doing? Well, I did a food drive, or I did a farmer's market, or I did this or I did that. And it's like, well, no, that's not social determinant work. I mean, it is, but it isn't. Or you start to talk to people about anchor institution work, and what do? Why hire local? Well, in all due respect, give me a break. I mean, if that's all you do is hiring people locally, I mean, that's a pretty low bar. Or you're buying local, pretty low bar. And so what happens, I think, is we are an industry where everybody checks box. Everybody's doing social determinants. Everybody's like this anchor institution thing. Everybody say, I'm doing it. But I think your point is, how do you begin to show it in a more significant way, get to a deeper level of discussion, and really drive more meaningful discussion and metrics? And that's a story, I think, that people are doing it, that have done it for a while, can tell more clearly and boldly. Because I think what's going to happen is what we see oftentimes is people say, yeah, I do that too. And I think where we're going to see fundamental difference, if we can either persuade, encourage, coerce people into doing more deep things. And I think that's going to take some work.
So to answer your question, one of the things that we do at Dignity Health is we do shareholder advocacy. And this is a way to use our financial arm to purchase stock in organizations that are not doing good things, to be able to challenge them to change their ways. For example, we challenge Walmart around access to health care for their employees, their wages. So we use whatever power we can by buying stock in these organizations to influence them in a good way to do the right thing. So that goes beyond just our neighborhoods.
Hi, I'm Celeste James with Kaiser Permanente in the Mid-Atlantic states. And when you asked the question just now about whether our CEO and leaders are directing us around this work, some of us were a little conflicted by that question, even though we raised our hands, and I will say I myself was, because I think to a very large extent, probably most of the people in this room have created the groundswell within their organizations that have created the leadership shift, and that we can take full credit for bringing the language, bringing this idea of social determinants of health into the organization in a way that the leaders are now creating the space for us to be able to do this work unapologetically. And certainly, as you had said, or someone on the panel said before, about we've been doing this without permission per se, and without even asking for permission, because it's the right thing to do. So I would, again, say that leadership is supportive and absolutely driving the momentum now that we're really glad to have, but the grassroots effort really is what has created this in most of our organizations, I would dare to say.
Just to add on to this, I think the power of the Democracy Collaborative Healthcare Anchor Network is to create a national unity around these ideas. I think we are in our infancy. Some of us, some around the table have been at this for a long time, but most of us have been at this for a very short time. The issues of measures, the language around it, and I think there's strength in these numbers to influence others, to have the kind of rigor that we need to advance this. So I thanks for the grassroots, because I think that's where these ideas actually bubble up from. But I think there's power in this network as well to advance the ideas. We have another question here.
Hi, good evening, and I am Janet Johnson. I'm the Economic Development Manager for the City of Richmond. I just want to, again, just welcome all of you. Thank you for choosing Richmond today to be here. And before I ask my question, I just want to speak to Kaiser's mission and just remind everyone here today, and especially Kaiser folks, that we are sitting in the Kaiser shipyards, and that ship out there that was built by the Henry J. Kaiser here in Richmond is why we have Rosie the Riveter Museum. So I just wanted to say that, to remind you of that, and so I just wanted to remind you of all of that. So my question speaks to anchor institutions being able to raise up small business owners as well as employees to a level where they can start to build wealth. One of the things that's been really difficult for small businesses is to get those contracts. I mean, I understand you hire someone to work on a job, on a construction job, then when the construction is over, it's done. But how do you get folks to become a part of your overall structure of continuing to build your structures and your buildings and really buying from those folks? And as we heard talking today of the 40-year partnership with Food Service Partners, I don't know how many brown and black and minority and women can speak to having those type of long-term, sustained relationship with anchor institutions. So I know it's really difficult because I work to try to finance small businesses, and I understand the whole not having the what you need to be bonded to work on this job. So I just want to just speak to maybe that's a way. You have to start building wealth. You have to figure out a way to start closing those gaps and making folks feel a part of the whole system.
For those of you who started the day out with us back at the Inn, I think that you may have seen some of the large posters, and on some of the large posters there was at least one Wall Street Journal article that talked about a local minority-owned vendor that we've worked with in order to literally get him from being just an entrepreneur to now being a small business that quite frankly is vending for us in the area of patient socks, but who we are hoping to grow into really having him service so many more than just the one healthcare hospital that he currently is doing. So, but what's important about that, the imperative there, is having a laser focus around how we need to do business with them differently, right? So you heard me mention earlier around the fact that really so many of our organizations have created a system and a structure of doing business which has just been exclusive